Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, colleagues, friends. Again, it's virtual as usual. We've been doing this for the last 3 years with my friend and colleague, president of the Emirates Neurology Society, Professor Suhail Al-Rukn. This is our third session together, and this is hopefully the best of the best. So we started with atrial fibrillation as a risk and to lead to the stroke and other things. We've discussed the hypertension as a risk from neurology and cardiology point of view. Today is the lipids, and we know how much lipids affect every aspect of atherosclerosis, starting from cerebral to the peripheral to the stroke. And today, to tell you about how bad it is when you get a stroke, what are the consequences of that. We'll have two speakers for this, and I'll let my colleague Suhail Al-Rukn to give you a welcome message as well. Then we'll start our program. Dr. Suhail. And unmute, please.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone. Thank you, Professor Abdullah Shahab, for this wonderful series of webinars between the neurology. Always heart is very important, but sometimes the brain is very important also. So today I was with one of our previous speaker, Dr. Maria Khan, educating more than 177 nurses across the UAE, Oman, Bahrain, and Kuwait about acute stroke management in the emergency and inpatient. During this webinar, I had two stroke code, Dr. Abdullah. One of them is 36-year-old gentleman with atrial fibrillation, very young, I'm not sure, but he was on warfarin when he presented. He went directly to mechanical thrombectomy at Rashid Hospital. Patients presented, Professor Hassan, with dense right hemiplegia and global aphasia. It was occluded. I can show you the images which will come here. And we were able to do a direct mechanical thrombectomy, and the patients recovered completely. Went from NI to stroke scale from 17, 18 to less than 2. And I'm not sure. Yeah, you can see it here. This is Professor Hassan occlusion of M1, and this is after the thrombectomy is done. Wow. Recanalize of M1. Then admitted another young patient who doesn't have atrial fibrillation, but he has poorly controlled high blood pressure and dyslipidemia. So we are speaking about a disease which is giving a bad outcome for our patients: disability, weakness, family impact, community impact. I'm so honored to be part of this webinar to educate people, and thanks for Professor Abdullah to give us this chance. Mike is back to you, Abdullah.
Great. Thank you very much. It's our honor, Dr. Suhail, to be with you. Actually, we learned a lot in this collaboration together. So without further ado, we're going to go to our program. It's always great to work with my friend and colleague, Professor Hassan Tamimi, one of really a senior consultant cardiologist and highly educated for everyone in this region. He will take us about the lipids and from cardiology perspective, how that help us to prevent and, when you get a stroke, how to manage that. Professor Hassan Tamimi, please welcome.
Thank you. Good evening, everybody. Thank you, Professor Abdullah, Professor Suhail. Thank you for the invitation. It's really a pleasure for me to be with you. I think it's fascinating the pictures that Professor Suhail showed us. It's really, I think, talking about a stroke in the context of a lipid, I think it's all to do with the vasculature. I think risk factors, as was mentioned early, hypertension, cholesterol, diabetes, smoking, they all impact the blood vessels. Wherever this blood vessel is, whether it's in the heart, brain, kidney, peripheral, it's impacted. And as you can see, it's a vicious circle. So patients present with coronary artery disease, chest pain, or myocardial infarction, stroke, and eventually heart failure. It's all a continuum of the same disease with different presentation. We're focusing today on the global look at vascular problem, and it all comes under the atherosclerotic cardiovascular disease, which encompasses coronary artery disease, which is MI, unstable angina, and so on, and the carotid and cerebral arteries, ischemic stroke, and TIAs, and the peripheral vascular. So this is a global look at the impact of today the lipid and lipid-lowering agents on the vasculature, with the focus on stroke. But as a cardiologist, we look at it in a global sense. It has to be said that atherosclerosis is the leading cause of morbidity and mortality globally. As we speak, the last minute, 34 people with atherosclerosis have died from MI or stroke. And luckily for Professor Suhail's patient, he was salvaged very effectively. So, but not everybody is so lucky about this. And it's all really about the risk factors. We are in the region. This is an eye-opener. The average age in the Gulf area for patients presenting with acute coronary syndrome is 10 years younger, 15 years younger, 58 versus 68, 10 years in Australia versus 68 in the US, and in Scandinavia, 73. 58 is a prime. This is the most productive time of people's life. And I think this is a major concept for us, to be aggressive in approaching risk factors. And as you can see, this is the Interheart study looking at the impact in 52 countries on modifiable, and I stress the point of modifiable in patients with myocardial infarction. And as you can see, lipid is a major issue. And I think it's for the last maybe 10 years or so, we were mainly talking about statins, still very effective, but I think we have evolved into a newer and very effective measures to really achieve the target where you can prevent this disease. And it's very simple. Looking at 26 randomized statin trials, 170,000 patients, 1 millimole reduction in LDL can reduce vascular events by 22%. This is major. And I think it really makes an eye-opener for us to realize the impact of reducing just 1 millimole, which is 40 milligrams per deciliter. And I think even the knowledge of the way we look at lipids, it's really evolved significantly. I want to just raise some issues here. We have multiple lipoproteins. Of course, LDL for us is key, but we have HDL, and then you have all the other subfractionation. I just want to, as you can see, all the HDL has an ApoA1, which is the receptor on this particular particle, versus the others have ApoB. This is key because when we say this is a good cholesterol, well, I mean, it's composed of cholesterol, but it helps taking the cholesterol efflux from the cell to the liver. That's why it's good. It helps cleaning of the cholesterol from the periphery, versus the others, they're all atherogenic. And as you can see, the composition of cholesterol versus triglycerides is the highest in the LDL. And so we have non-atherogenic, or the good cholesterol, which is the HDL, and all the other particles are all atherogenic. And usually it's a good idea to look at the non-HDL, because if you look at simply the LDL alone, you miss all the other cholesterol that you have in the other particles. So this is a better formula for us to assess the amount of cholesterol that the patient has. And it's usually now measured part of the lipid profile, and it's worthwhile looking at it. I think for a long time, we focus on LDL, but I think there are new particles around now that have shown by studies and recently by therapy that they have a major impact. Unfortunately, we have failed as of yet to get a medication that increases HDL. but we've been very effective in impacting LDL. But there is a new molecule that I would spend a little bit of time on today, and that's Lp(a). We knew it's important, but now we have therapeutic intervention for it. So in the next few minutes that I have for this lecture, I'm going to focus on 3 particles that have direct impact on the vascular wall, leading to atherosclerotic cardiovascular disease, whether it's a myocardial infarction or a stroke, and namely the impact of LDL, triglycerides, and Lp(a). This is the global map of the current or lipid-lowering agents. Of course, of significance are the all trials that we have for many years now. It's the placebo-controlled status, which were the initial trials. Of course, subsequently, we were not able to do a placebo because of the benefit. And then subsequently, we moved to looking at agents that have low efficacy or low potency statin versus high potency. We have added a non-statin in the form of ezetimibe. We have recently have the PCSK9, whether it's the monoclonal antibody or the small interfering RNA. And I'm going to cover a little bit of this to give you a global look at the newer therapies that have really impacted our practice in cardiology in particular, achieving a very good levels as per the guideline. So these are the trials that looked at placebo versus statin, and this is a meta-analysis, about 90,000 patients in 14 trials, looking at the outcome, whether it's non-fatal MI, cardiovascular death. This side is the line of identity. Lower is statin is better. This is control. And as you can see, all the endpoints, whether it's non-fatal MI, cardiovascular death, PTCA, or coronary vascular, statin has performed beautifully. Now, looking at the stroke, it's interesting that for ischemic stroke, significant impact, hemorrhagic stroke, actually it's more control is better. And I think this is some issue we may discuss a little bit later. The point here is statin have shown over the years to be significantly impacting the outcome in all the cardiovascular, whether it's cardiac or cerebral. Then we moved on to looking at low intensity versus high intensity statin. This is the PROVIT 22, TIMI 22, looking at Prava 40 milligram versus Atorva 80, and outcome again looking at death, MI, and stroke. There's a 16% reduction in the patient who received the high statin intensity, and reducing LDL significantly, and of course impacting outcome. So this is a shift moving into whether we need to move from the low intensity to the high intensity. Then we have the Treat to New Target TNT trial, a very important trial, about 10,000 patients, looking low dose versus high dose. So high intensity, Atorva 10 versus Atorva 80. Because the knowledge that we have has evolved over trials, and the guideline that we have today has evolved significantly. In the early statin trials, the LDL starting off was 190. And because they thought getting lower maybe it's not a good idea. And the knowledge has evolved. So now this trial thought there is a 22% risk reduction by using atorvastatin 80 versus 10. And now we have a new level of LDL in that regard. And if you look at the stroke here in that particular area also, fatal or non-fatal stroke, there's a 25% reduction in the stroke in patients who receive the high intensity statin. Then we moved out a little bit and using a non-statin in the form of ezetimibe in combination with a statin. And again, over a span of time here, the study went on for 7 years. There was a significant reduction in LDL with a modest reduction in outcome. So adding a non-statin to a statin has added further benefit. And I think the combination is critical for us now in patients who undergo PCI. Now, this was really, in my mind, one of the most important trials in the statin versus placebo. This is the Jupiter trial, looking at 17,000 primary prevention. These are healthy men and women who have modest LDL, 130, which is really not that high. But what they have high CRP. So they have some inflammatory process. Inflammation is key. Really, we've seen it through COVID. It's what makes the plaque rupture. So measuring hsCRP is specific for the heart, and it's a very good parameter to look at. So, and they randomized them to Rasuva, not that very high dose, 20 milligram versus placebo. There was a 44% highly significant reduction in the outcome point, cardiovascular death, non-fatal stroke, non-fatal MI, amazing result in patients who do not have symptoms. So the disease is there. And I think, unfortunately, when you hear the social media talking about the problems with statin and all the rest of it, it's really quite disappointing. This is what treating a lipid does in even patients who have no symptoms. And I think that raised the issue about the benefit of statin beyond the lowering LDL, and that's impacting inflammation. So in the acute phase, patient having an MI, you do not lower LDL that quickly, but you get the benefit within few hours because of the impact on inflammation. That's why in most of the acute case, we give high dose of statin, but to really reach the level of LDL that we look, it may take months, but the benefit on the vascular endothelium and inflammation is quite significant. So as you can see, this is the initial primary versus secondary looking at outcome. And as you can see how for us, the initial trials. Now this is Jupiter from 130 came down to 50. So then what's next? The question is, are we done with the lipid? I mean, how that is, I mean, using all the elements. And I think therefore, but it's not really, we're not done because despite the incredible reduction in outcome in all the statins, which is 44 is the maximum, there is a lot of residual risk left. Now, is this a lipid or is it something else? So then we came up with I think we had like a few years, I mean, it's, I think 10 years ago, and it was mainly statin, that's all. I mean, and then we have really a very interesting breakthrough into the lipid management, and that's the PCSK9 inhibitors. And this is a very nice story because it shifts really. What matters in treating statin is the LDL receptors. LDL receptors play a major role. They sit on the surface of the liver and regulate blood cholesterol levels. And PCSK9 is a protein that degrades the receptors. So the receptors are key to get the cholesterol going. PCSK9 gets out of the cell and leaches into the receptor. And let me show you the discovery of the LDL receptors was Brown and Goldstein got the Nobel Prize in 1985. And this is what we don't talk about. This is the surface of the liver. This is the LDL receptor, and this is the LDL particle. So what happened is the LDL particle has to see a receptor. That's why I showed you the ApoB. This is the ApoB. It's a receptor that recognizes the receptor. So it sits on the receptor, and then it goes into the liver. So the complex of LDL and receptor goes into the liver. The LDL undergoes degradation, and the receptor goes up back to the surface. And each receptor can recycle by 50 times. So the difference between you and me having good cholesterol is how many receptors you have. If you have lots of receptors, you have very low LDL. You have the familial hypercholesterolemia, some of them have absolutely no receptors. And that's why they literally have the LDL circulating in the vasculature. Anyway, so PCSK9, these are the proteins. They come and attach themselves to the LDL receptor, and therefore, when the LDL comes and attaches to the receptor, you have a complex of receptor, LDL, and the PCSK9. But what happened is the PCSK9 will not allow the receptor to recycle. So the whole complex will disintegrate, and therefore we lose a receptor that it should recycle 50 times. Now, when you give the monoclonal antibody, these are the PCSK9 inhibitors, and you can see them here, they attach to their protein, preventing it from attaching to the receptor. So freeing the receptor, and we go back to the cycle of degrading the LDL and recycling. And that's how PCSK9 is given. So PCSK9 lowers LDL by facilitating clearance. And I think this is key because statins block the formation of LDL, the cholesterol. That's why you get the muscle aches and what have you. Here, you're just facilitating the clearance. That's why PCSK9 inhibitors have no issues with the side effects. But the point is they're quite expensive. They're giving into monthly, twice a month, or bi-month. So either there is every 2 weeks, or now recently there is one which is given monthly, which is an injectable because the monoclonal antibodies are digested. But the news is, I think there will be an oral PCSK9. So I think it's really quite interesting. Now, so two major trials. I think for us, what's the outcome? So one, Evolocumab is 27,000 patient monoclonal antibody PCSK9 inhibitor looking in patients with stable atherosclerotic cardiovascular disease. Odyssey is 18,000 in patients with acute coronary syndrome. Those patients were optimally treated by high-intensity statin plus a non-statin. So they were optimally treated. You cannot leave them versus placebo. And then they were randomized to the PCSK9 inhibitor or a placebo. And the outcome, again, MI, stroke, in both the follow-up between 26 to 34 months. And massive reduction. You know, you have to realize that those patients were already on maximal statin or non-statin, between 50 to 60% reduction in both trials in the LDL. And that, luckily, translated into not very impressive, but still a highly significant reduction. So there is still residual benefit by pushing cholesterol down a little bit more. So we have about 18% relative risk in both trials, whether patient is in stable or in acute setup. This has really opened a huge impact. And I think the whole guideline changes because now we can reach LDL of 30, 40. Some of those patients, they go to up to 10. We had another breakthrough, and that's even a more sophisticated aspect. And that's really blocking or degrading PCSK9 even before it leaves the nucleus. So before it circulates and goes to the receptor itself, no. This is the small interfering RNA. It imitates when the PCSK9 protein goes out of the cell nucleus, it attaches itself to it and degrades it. So even it didn't have the chance to get out to be attached to the receptor. And that's the latest. And therefore, we have now a target delivery of small interfering RNA to the hepatocyte where it prevents PCSK9 translation and synthesis. And this, the issue is that it's being used every 6 months. So not only we have a different mechanism, but even the span. We usually initial dose 3 months and every 6 months. So that's another breakthrough. And again, the Nobel Prize was given for these two scientists for identifying the RNA interference. And I think most of the vaccine on the COVID and what's coming up is using interfering using the RNA interference to go in and attack or destroy the protein that forms the virus, in this case, the protein itself. There is no outcome trial yet for this, but the effectiveness in a phase 3 trial have shown again a highly significant reduction in LDL. Again, as you can see, you inject initially at 3 months and then every 6 months, with an average between 60 and sometimes 70 milligram reduction, and it's maintainable over that time. Of course, we still have to. I think I've had some quite experience with this new, but you know the reason why we jumped onto this because we have experienced quite a good safety record for the monoclonal antibodies over the last 6-7 years, and the initial response is quite interesting, and we haven't seen. I have about 12 patients on the new modality, and it's safe and very effective, but of course we have to wait for the outcome. Now, triglycerides, another story. It's been disappointing. Many trials looking at the fibrate did not show any outcome benefit. Unless you look into specific patients who have high triglyceride, you get the benefit. So the guidelines sort of really changed whether to treat or not treat, and there was a huge debate. Until recently, this is a trial. Of course, as always, we treat to impact outcome. We don't treat numbers. I mean, if you need to treat, whether you go aggressive or not, to impact outcome. This is a very interesting trial for the first time that they're looking at 8,000 patients with diabetes already on statin and have cardiovascular risk factor. They're fasting triglyceride at 135 to nearly 500. And they were randomized to icosapent ethyl. This is omega-3 fatty acids, high dose. And as you can see, there's a significant impact on outcome. Again, similarly, cardiovascular death, stroke, coronary revascularization, 28 versus 23 using the new medication, very highly significant. And you need to treat 21 patients to save 1 life. So this is really a solid trial to show that triglyceride does matter. And we have to be also looking at that. The only issue that, and I've used it quite a bit now, I had 2 patients having atrial fibrillation. Omega-3 fatty acid, in general, in high dose, they do give you arrhythmia. But here, it's a significant impact. And luckily, one of the patients was, we're talking about AF earlier, it's a serious side effect. And luckily, some of those patients were under, they didn't achieve the CHA2DS2-VASc for anticoagulation. But so, unless it's, today I had somebody with triglyceride of 17. So initially, an idea to go first with the fenofibrate plus 1 gram of 2 grams of omega-3. And if it doesn't work, then you go to the new medication. It's called Vascepa. So it's another medication that we have, but we have to be careful, particularly in the elderly. The last bit that I want to touch base on is Lp(a). Now,
maybe, Dr. Hassan, we are running out of time. If you maybe can conclude.
Yeah, let me just go quickly. I just want to say this is an LDL and atherogenesis. So this is a thrombo and atherogenic particle, and if you look at the risk, if you have risk and you add the Lp(a), you really impact. And it's genetic, you need to test it once in a lifetime. And if it's high, recently we looked into it, and some of this patients that did PCSK9, statin do not impact it. PCSK9 does impact it, and now we have phase 3 trial that's going on that has a major impact on Lp(a). So my point is, we look for all the residual impact. So whether it's cholesterol, whether it's inflammation, thrombosis, triglycerides, Lp(a), and diabetes with the new medication SGLT2 and GLP-1. So in conclusion, lowering LDL is effective in atherosclerotic cardiovascular disease prevention. Statin, ezetimibe, PCSK9, they were drugs without outcome data, bempedoic acid and glycerin. We need to think beyond LDL. Lp(a) and triglyceride are causally related to ASCVD. Lipid-lowering therapy is getting more complicated. New treatment target, mRNA-based therapy. Getting close to individual tailored therapy. Big question about the incremental benefit, cost, and complexity. Thank you very much.
Thank you very much. This is a great wealth of information. Normally with lipids, sessions, it takes 2-3 days conference. I mean, Dr. Hassan did it for you in less than 30 minutes. Thank you very much. We move to the next topic, then we'll have discussion after because we want to keep time for this. Dr. Suhail, you can introduce a second speaker, please.
Thank you, Dr. Hassan. Thank you, Dr. Abdullah. What a nice presentation, Professor Hassan. Jazakallah khair. Our next speaker is a close friend and colleague, Dr. Purnami. Dr. Purnami did her training medical school in India. Then after her bachelor, she proceeded with her residency neurology program. Then she did a movement disorder subspecialty. Dr. Purnami has been member of Rashid Hospital for more than 6 years. She was in charge of the residency, the only neurology residency program in UAE. She was running this program for almost 4 years. Then she moved to Al Qasmi Hospital, where she's running the stroke service at Al Qasmi Hospital as a consultant neurologist, and she's very active in educating nursing, physician, emergency, and others about stroke. Today, Dr. Purnami is going to update about stroke and dyslipidemia, and we are waiting for you. Mike is yours, Purnami.
Thank you very much for your kind introduction, sir. Actually, Professor Hassan Al-Tamimi had made it very simple, actually. When it comes to stroke and neurology, dyslipidemia is a poorly understood topic. When anybody asks us about the BP guidelines, the sugar guidelines, we are very sure about it. When it comes to dyslipidemia beyond statins, it's a little tough. Usually, when the patient doesn't get control with statin therapy, we take the help of internal medicine or endocrinology colleagues for the better control. Also, the stroke, dyslipidemia, and cardiovascular dyslipidemia cannot be separated. The atherosclerotic risk factors, as Professor Hassan has brilliantly explained, it's one and the same. When it comes to dyslipidemia management, usually the cardiologists are a step ahead of neurologists. Most of the basic concepts he has explained it very well. So the things which I tell will be either a repetition or a few concepts based upon the basics which he has very well explained. So let me go to the slides. So dyslipidemia, as I told, the management of dyslipidemia is one and the same for cardiovascular disorders and cerebrovascular disorders. And that's why I think Dr. Suhail and Dr. Abdullah has selected a cardiologist to speak about dyslipidemia when it came to fighting stroke. So why should we treat dyslipidemia? When should we treat dyslipidemia? Whether it should be a primary prevention or a secondary prevention? How long should we treat? Which medicine should we choose? And other than the medication, are there any non-pharmacological options? So we will answer these simple and practical questions. So as he has explained, the cholesterol particles are divided depending upon the size and the density. And high density lipoproteins are the most dense and very small molecules. So they stay within the blood, and it helps, as Dr. Hassan told, it helps the removal of the other lipid particles from within the liver. But when it comes to VLDL, very low density lipoprotein, intermediate density and low density lipoprotein, the particle size is big. And these are the VLDL, LDL, IDL. Those are the ones which get deposited in adipose tissues, heart muscle, and also it produces atheroma formation because it gets deposited within the macrophages as well. Whereas HDL doesn't get deposited in these target organs and it doesn't result in atherosclerosis. When it comes to insulin resistance, the things are a little more complicated because there will be more of synthesis of VLDL and LDL and more of accelerated atherosclerosis. So why should we treat dyslipidemia? When it comes to cerebrovascular diseases, 2 randomized control trials, the SPARKLE, the stroke prevention by aggressive reduction in cholesterol levels, and TST, treat stroke to target evaluated lipid lowering therapy in patients after ischemic stroke. And both these trials unanimously found out that there is significant benefit from cholesterol lowering therapy in preventing vascular events, including stroke. The SPARKLE found that atorvastatin 80 mg daily reduced stroke recurrence in patients without another indication for statin therapy. TST confirmed that a target LDL level of less than 70 was superior to a target level of 90 to 110. There are several other studies which have shown that the cardiovascular mortality is dependent upon the total cholesterol HDL ratio and log of the total cholesterol to LDL ratio. So more of LDL and less of HDL, both of which are atherogenic and results in ischemic strokes. But when it comes to hemorrhagic strokes, the lipid levels, the risk factor as if dyslipidemia is poorly understood. In fact, there are certain trials which have shown that high-dose statin therapy may increase a risk of hemorrhagic stroke as well. So, that is about LDL. How about hypertriglyceridemia? Moderate hypertriglyceridemia, whether it is a fasting or a non-fasting sample. Moderate means 175 to 499. It carries the triglycerides are carried in very low density lipoprotein. Severe hypertriglyceridemia, the VLDL gets saturated and then it gets carried with the chylomicrons. So VLDL, as we know, it is atherogenic, similar to LDL, and that's why hypertriglyceridemia also becomes atherosclerotic. So severe hypertriglyceridemia, because of the increased VLDL, it poses a risk of atherosclerotic cardiovascular diseases and cerebrovascular diseases, whereas increased chylomicrons, it results in a risk of pancreatitis. So we know that we need to treat dyslipidemia to prevent or as a secondary prevention for stroke and cardiovascular diseases. So when should we treat? Whether it should be a primary or a secondary prevention, and which medicine should we choose? The recommendation by American Stroke Association, American Heart Association, they say that patients with atherosclerotic cardiovascular diseases should receive high-intensity statin therapy. And after high-intensity statin therapy, if the LDL cholesterol remains more than 70, then it may be reasonable to add an ezetimibe and then a PCSK9 inhibitor. So what does these medications do? Statins, we know that those are HMG-CoA reductase inhibitors. So it results in reduced LDL, IDL, and VLDL. The ezetimibe, it reduces the intestinal and biliary cholesterol absorption. And anti-PCSK monoclonal antibodies, it acts on the LDL receptors and reduces the LDL levels. So then another thing is, should we always need a fasting lipid profile or a non-fasting levels should do? Because always we ask for a fasting lipid profile and the patient is not fasting and we don't get it done. So what they say is modest differences in LDL cholesterol levels are associated with postprandial state, and hence a non-fasting sample is as effective as a fasting sample for initiation of statin therapy. Now, we told atherosclerotic cardiovascular diseases. What are these high-risk atherosclerotic cardiovascular diseases? So the major atherosclerotic cardiovascular diseases include history of ischemic stroke, recent acute coronary syndrome within the past 12 months, history of MI, symptomatic peripheral arterial disease with history of claudication and ankle brachial index less than 0.85, or a previous revascularization or amputation. And high-risk conditions include an age more than 65, heterozygous familial hypercholesterolemia, history of CABG, or PCI, diabetes, hypertension, chronic kidney disease, and current smoking. So the stroke recommendations, they say that in patients with ischemic stroke with no coronary artery disease and no major cardiovascular disorders, LDL cholesterol more than 100 and LDL cholesterol more than 100, atorvastatin 80 milligram is indicated to reduce stroke. But in patients who have history of ischemic stroke and atherosclerotic disease, in patients a target of less than, to reach a target of less than 70, you can add an ezetimibe along with high dose therapy, statin therapy. And despite statin therapy, those who are at very high risk, defined as stroke plus another major atherosclerotic cardiovascular disease, or stroke plus multiple high risk condition, that means current smoking, or chronic renal failure, and age more than 65, and they are already taking maximally tolerated statin and ezetimibe therapy, and LDL cholesterol is still more than 70, then you have to choose a PCSK9 inhibitor therapy. Hypertriglyceridemia, if the patients are already on statin therapy and the HbA1c is less than 10 and there is no history of pancreatitis, you can go for an icosapentethyl 2 gram twice daily to reduce the risk of recurrent strokes. But in patients who have severe hypertriglyceridemia, despite statin therapy, you can omega-3 fatty acid and fibrate therapy may help preventing pancreatitis and further cardiovascular disorders. So once started on medications, how long should we treat? In patients with stroke or TI and hyperlipidemia, you have to check periodically. So once started, you have to check it at from 4 to 12 weeks, and then thereafter every 3 to 12 months to see whether the patient's the target is met or not. So the goals and clinical efficiency of LDL cholesterol lowering are defined and monitored by percentage of LDL reduction. Usually, adherence to LDL lowering diets alone, it will reproduce a reduction of 10 to 15%. Moderate intensity statins produces a reduction of another 30 to 49%. High intensity statins more than 50%. Adding ezetimibe or a bile acid sequestrants along with statin an additional 15 to 25%, and adding a PCSK inhibitor to statin plus ezetimibe causes greater reductions. So once we start on statins and LDL, should we start on statin if the LDL cholesterol levels are normal? So statins exert a neuroprotective, microvascular, anti-inflammatory beneficial effects in animal stroke models. So it is recommended that even if the LDL levels are normal, high dose statin should be given in the acute phase. And also long-term statins, even in moderate dose, is recommended to achieve tight LDL levels. And again, how long you have to continue on statins? We know that lifestyle changes and statin therapy are commonly introduced together, and the maximum percentage change occurs in 4 to 12 weeks. So after 12 weeks, we periodically check. So after 12 weeks, once the levels are normal, what should we do? Again, we have to categorize, like depending upon the age of the patient, depending upon whether it is a primary prevention or a secondary prevention, and depending upon the comorbid factors also, we need to choose how long and what dose of statin has to be continued. Most of these guidelines are, as I told, these are adapted from the cardiology guidelines. So we have to first categorize the patients depending upon the atherosclerotic cardiovascular disease. So very high risk means a calculated score of more than 10% for 10-year risk of fatal cardiovascular diseases. High risk means a score of 5 to 10%. A moderate risk is a risk between 1 to 5%, and low risk is less than 1%. So depending upon these risk factors, we have to decide what LDL target level we have to choose and how long we have to continue on medications. So atherosclerotic cardiovascular diseases, it's very high risk diseases, as we know, like as we already mentioned. If there is a history of MI, a history of stroke, then already they qualifies for that. So for those who do not have these established clinical events, again, imaging modalities like coronary angiography, CT coronary angiography, or a carotid ultrasound showing vascular stenosis, it indicates that they are at very high risk of developing cardiovascular or cerebrovascular disorders. Diabetes mellitus with history of target organs or more than 3 risk factors or early onset of type 1 diabetes mellitus more than 20 years should be considered as a high risk individual, and high weight and control of LDL has to be looked for. Severe chronic kidney disease, familiar hypercholesterolemia with atherosclerotic cardiovascular diseases or other major risk factor also should be considered as a very high risk individual for developing cardiovascular disorders. High risk patients are those who have a triglyceride level more than 310, LDL cholesterol more than 190, or a BP more than 180, 110. Patients with familial hypercholesterolemia without high risk major high risk factors. Patients with diabetes without target organs damage or moderate chronic kidney disease, they are at high risk. Moderate risk are young patients, those who have type 1 diabetes, or a type 2 diabetic patient who is less than 50 years. When it is type 1 diabetes, less than 35, type 2 diabetes, less than 50 years, with a diabetic duration of less than 10 years and without other risk factors. Rest of the patients should be considered as low risk. So depending upon the guidelines for primary prevention, what they say is a patient who have any of these risk factors always look for an arterial plaque burden, either by an arterial ultrasonography or by ultrasonography or an angiogram to assess whether they are at risk, high risk or moderate risk. Cardiovascular imaging to see for the coronary calcium score also, it also will help to assess the risk of the patient. Lipid analysis, like Professor Hassan already mentioned, not just LDL levels, you can look for the lipoprotein A levels also to see whether the patient is at risk of developing the cerebrovascular diseases. Patients with hypertriglyceridemia, they say that also needs to be treated, which is a new guideline. Previously, it was just based upon LDL. So now they stress more on lipoprotein A and triglycerides as well. Patients with familial hypertriglyceridemia also should have a tight target of less than 55 milligram per deciliter and not 70. For older patients, treatment with statins is recommended for primary prevention according to the level of risk, especially in patients less than 75. Initiation of statin treatment as a primary prevention should be considered if at high risk, even if they do not have any cardiovascular or cerebrovascular history of clinical events. And lipid lowering agents, if the patients are having recurrent events, or if the LDL level targets are not met, you have to go for PCSK inhibitor early before waiting to add another therapy and to wait for long time before that LDL target is met. And patients with diabetes mellitus, as I already told, we have to keep a tight target. If the patient is a very high risk individual, the target is not 70, it is 55. If it is a high risk individual, it is 70. And any patient with type 1 diabetes who are at high risk or very high risk, we have to start on statins. And intensification of statin therapy is recommended depending upon the risk as well. And also, currently they say that ApoB analysis also is recommended for patients who have hypertriglyceridemia, obesity, metabolic syndrome, and non-HDL levels, or like hypertriglycerides, LDL, and lipoprotein A also has to be checked for. And LDL lowering, if the statins are not helping much, then you have to add ezetimibe and followed by a PCSK9 inhibitor. And hypertriglyceridemia management, we already mentioned, like we have to go for reducing the target level to less than 2.3, so 200 or above with a risk factor. You have to start on statin therapy even if it is isolated hypertriglyceridemia. It is more so if the patient have history of heterozygous familial hypertriglyceridemia, or if the patient is of high age, or if the patient has any history of acute coronary syndrome. And is there any non-pharmacological option? So again, the risk stratification is, again, it is very important for primary prevention. For the patients who have a very high LDL level, more than 190, you don't have to wait for any risk factors. So you have to start on lifestyle intervention and concomitant drug intervention. If for the patient who are at moderate risk, and if the LDL level is 2.6 to 3 itself, that is more than 100 itself, you have to start on a drug treatment. For patients who are high risk, even the levels less, like LDL level less than 100 also, you have to start on therapy. And if the patient has a very high risk of cardiovascular disorders, if the LDL level is 70 itself, you have to start on medications to prevent cardiovascular disorders. So again, what other things can be tried other than medications? So the things which we can try, other non-pharmacological measures, are trying to avoid dietary trans fat, reducing dietary saturated fats, increasing the dietary fiber, functional foods enriched with phytosterols, reducing the red yeast rice, reducing body weight, reduce dietary cholesterol, and habitual physical activity. Also, alcohol intake reduction and habitual physical activity will improve the triglyceride levels as well. HDL cholesterol, as Professor Hassan mentioned, there is no medication which can increase the HDL levels. The best thing is to increase the physical activity. That is the one thing which can help increase your protective cholesterol levels. Avoiding dietary trans fats can help. And also you have to reduce the dietary carbohydrates and replace them with unsaturated fatty acids. Modest consumption of alcohol, that's doubtful. Smoking cessation is a must. So intensity, the lipid lowering drugs. So how good are they? Moderate intensity statins, it reduces the LDL levels by 30%. The best thing is PCSK9 inhibitor plus high intensity statin plus ezetimibe. It can produce LDL reduction to as good as 85%. So usually once we start on, first we assess the baseline LDL levels, and then you look for the absolute reduction, and then you look for the relative risk reduction, and then you go for the absolute risk reduction. So patients who are, so first of all, when you see a patient, you see what all risk factors he have, whether he is a very high risk patient, high risk patient, moderate risk patient, or a low risk patient, and depending upon that you set your LDL goal, whether it has to be less than 70 or less than 55, and based upon that you start on your medications. You start with high potency statins first. If the target is not met in 3 months follow, add ezetimibe. If the target goal is still not reached, you can you can add for a PCSK9 inhibitor. Why this, Professor Hassan already mentioned, PCSK9 inhibitor doesn't have much of side effects and it is very well tolerated. But why it comes last? It is because of its prohibitive cost. So again, as I mentioned, you go for the risk reduction based upon the risk individuals. For very high risk individuals, the target is 55 milligram per deciliter. For high risk, it is 70. For moderate risk, 100 is acceptable, and very low risk patients, 116 or less is an acceptable target for the LDL levels. So when it comes to cerebrovascular or cardiovascular disorders, for lipid lowering, definitely we know that it is a risk for the development of cardiovascular and cerebrovascular diseases, just like hypertension and diabetes. So any patient, you assess the risk And if the patient is a high-risk individual, decide for primary prevention. If it is a secondary prevention, irrespective of the levels of LDLs, you have to start on high-risk statin, and then ezetimibe and alirocimab according to the levels of the LDL levels. And you have to go for long-term treatment to achieve target levels, and also to have the protective effect of statins to prevent the endothelial damage and the atheroma formation. Thank you.
Great, thank you very much. Right, okay, I think we'll have time now for discussion, and I'm not sure if we have any questions from the attendees. Maybe Ziad, tell us if any, there are questions, so we can, me and Dr. Suhail. So let's just go back to what we do in clinic. We had a lot of theory and a lot of literature and studies here, just to people like to digest this. I think better to put it in what we do in real life. So just giving an overview. I mean, all of you know, we've done many studies, registries in the Gulf, and really we're looking to see if the people we have, when we give them medication like a statin or something, ezetimibe or PCSK9, what happened to their goal? Because if you, as Dr. Hassan said and Dr. Pormani says, we need to categorize them: low risk, intermediate, high risk, very high risk. We found, and Dr. Hassan agreed with us, we've seen this, and we always say this: those who are very high risk, and somebody had a stroke, somebody had a MI, a recurrent MI, for example, these are the ones who are lowest percentage in getting to their goal. And that's very bad. And those with the low risk, somebody like primary prevention, you can call it, they are doing slightly better. So many reasons for that. There's something to do with us as a physician, something to do with the patient, something to do with the system itself, and the medication, of course, not to forget. Adherence is very bad, doctor. If you look at, again, we did a study, less than 50% remain on their medication. So it's all to do with, we have great physician here with us. I know you are great, but not everyone like you guys. So we need to give time. You need to invest some. So let us talk about, we know that how important LDL is. We know this. We know how to prevent stroke, and by really targeting LDL through lifestyle and medication, but adherence should be there. Otherwise, medication will not work. I want some practical tips from Dr. Suhail, Dr. Hassan, and I will give as well my opinion. Purnami. So please, we start something practical for our people. Dr. Suhail, you want to tell us what you do with your stroke patients as a primary and as a secondary.
I love, thank you for asking these questions, Dr. Shihab. I was amazed with the presentation and the review that Purnami did, but I would like to listen to what Dr. Hassan Tamimi is doing in his clinic, because one of the challenges that we have as a neurologist that most of our patients who's coming with cardiovascular disease, we prefer that the cardiology is prescribing their treatment. But what I saw in my practice that many of the neurologists or the internists in general or family doctor, when they will start with the statin, they will start on the small doses, and they will start with 20 Lipitor, and if they will push them to put the patients on 40, they will be shocked that patients on 40, despite the Sparkle trials came with the 80 milligram, but we are under medicated our patients. So how's Dr. Tamimi is doing with his patients?
Thank you for putting me on the spot, Dr. Suhail. No, I think you're right, but mindful of the notion of side effects. I think, first of all, we need to establish that patients respond to medication differently. And the increase in dose does not reflect further reduction as per the dose. So I personally look at I assess every patient comes, and I have either the Framingham or I have the American Heart on my computer, and I really need to talk to the patient, and I risk stratify them, because just saying take the medication doesn't do it. And we talk about smoking, all the rest of, and I can show the patient. I have two monitors, one is with the patient and one with mine. And I just say, let's say we stopped your smoking, the risk drops. Patient can see the risk drop. your LDL is so much, and now if you bring it down, the risk drops further. So visually, and interaction education is key for the patient, number one. Number two, as I said earlier, there is a huge social media issue about statin. I mean, I think, and frankly, there is some side effects. Now, definitely for me, I mean, as a cardiologist, we are very aggressive and I need to get to target. Now, I may not do it. Somebody who has PCI or surgery, they have to be brought down. And I think the patient is interested. They have this post-procedure fear. So it's possible. But in general, and I tell you, if it wasn't for not the cost issue, and I think we need to, maybe this is a bit provocative for me to say, I would put everybody on PCSK9. But the problem is cost, because I can tell you, you achieve amazing result. And this cascade of adding statin to ezetimibe, I mean, yeah, it's because of one trial. But frankly, many times I have patients on the combination and the PCSK9, and I can reduce the statin and I keep the PCSK9 and we get excellent levels. But the problem is it's quite expensive and injectable. Now we have the 6 months, it helps. So there are many factors. In the future, if we say the oral PCSK9, which is now we are phase 2, come up, and then you start having more generic of that, I can promise you from now that PCSK9 is going to be the way ahead with those patients. And again, for patient, we need to get to target. There is no point in just wasting time. And I bring my patient, and by the way, I don't do fasting at all. And I think there is a notion, the guideline does not support, and even triglyceride, if somebody comes to you non-fasting and their triglycerides is 12, you know for sure that they have major hypertriglyceridemia. And now, in certain patients who have strong family history, I do the subfractionation, and I've been doing it for years. The LP, the HSCRP, and all the rest of it. So there's so much you can do to patient to reduce their risk.
Interest. Abdullah, you are muted.
Okay, what I want to say, you know, I mean, that's a good question. You put the things in our, because I wanted really, because since we are fighting the stroke, I wanted to know what you do, and that's good. So because this communication, I think, you know, make our goal, so we can critical thinking. Maybe our practice is wrong. Maybe our practice is not up to date. So this, I think, you know, communication and collaboration make us, you know, with critical thinking, make us to, you know, to reach that to the decision. So everyone we categorize, you know, especially our cases are normally very high risk, or I can say it's very, very high risk. Never is not less than that. And we always want their LDL to be less than, you know, more than 50% reduction. So if I can tell you about the, you know, publication we did on Emiratis, 5,000 Emirati who had MI, for example. Okay, they had LDL around 80, which is not bad, huh? So that 80 should go below 40. I wanted that to be happen in 6 weeks. So how can I reach that? I have to start with high statin, but patient not tolerating. So my goal to give them 80. If not tolerating that, I give 40 with ezetimibe. So 40 with 10. If patient not tolerating this, PCSK9, 3 things together. That's what we do nowadays. We give ezetimibe, high dose statin with PCSK9. Now, what after? The cost is an issue. Of course, that's why you need to sit down and discuss. But the most important, something like your case, doctor, somebody with ischemic stroke, for us regarded as a very high risk as well. So to prevent this from lipid point of view, we have to do the same. So the problem is the issue of the adherence, of course, and the side effects of this medication. But again, believe me, the side effects is not that bad if the patient knows it in advance, because there's something called nocebo effect. You know, if you tell him, he will get it. You know, but by understanding that he will go away, you can. Problem, we don't have time sometimes. That's the problem. But I want to know. I want to hear from you. What you know, what we do in terms of lipid in your clinic after a stroke.
Interest. There's a discussion which I can take it from here with Pournami. So usually Pournami, when we are getting an ischemic stroke patients and ultrasound showed that there's a clear extracranial hypoechoic plaque, which is sitting there. Most of the time, these are cholesterol plaque. And definitely patients will need to be on a high dose of statin. If the lab showed that his LDL, triglyceride, and total cholesterol is high, and usually 80 is the standard, and that's what we start with. Second thing, cardiology will be definitely involved with these patients. One of the common things that Dr. Tamimi that we are seeing in our inpatients is the intracranial disease. Many of the Indian, far Asian, our Eastern Asian, that they have a severe bad intracranial disease. And most of the time that these are M1 stenosis due to a plaque which is sitting there, and most of the time is cholesterol or lipid deposition there. You will be surprised that when I came from Canada, that the number of stenting patient or carotid disease that need a surgery is, we are doing 1 to 2 per year maximum, compared to Canada where we are doing 3 to 4 per a week, maybe in a big center there. But come to the intracranial disease, is hugely common in our society here, which indicate again that there's a different genetic between our community and the others. And I believe the young patient who's having a bad cholesterol and they are not treated because of genetic factor or their dietary issue that they're having. So we believe intervention with a high dose of statin cardiology to get these patients on the right target things from Al-Qasmi Hospital.
Same thing actually. Our population somehow doesn't tolerate very high dose. 3 months, always invariably they will come with muscle aches. Tolerability is very less. And that goes, so I completely agree with Dr. Hassan. Like if there is a tolerance is not coming down, you have to go for PCSK9 inhibitors, because the locals are completely insured and early locals. I see a lot of patients on, first of all, it is a monthly injection, and hence the tolerance also, and their LDL cholesterol is well. One thing. Second thing, pill burden when it comes to medication, aspirin, clopidogrel, atorvastatin, ezetimibe, no patient is going to continue on all those medications for long. So I think, Dr. Abdullah, you have to look for patients who are taking these PCSK9 inhibitors versus statins, and you have to follow and see for 5 years, 10 years to see like what percentage of them there are cardiovascular diseases or cerebrovascular diseases. Because statins, they say that other than the LDL reduction, there is some effect on the endothelial stabilization and the protective effect on the endothelium as well. So whether the same effects are there for the PCSK9 inhibitors, and if they are very well tolerated, I think over time PCSK9 inhibitors will replace statins.
Yeah, I think that's a great communication, and I'll let Dr. Hassan to answer, but I need to just, I think this is communication is important, because, you know, we do a lot of education on this. The problem, we are not communicate with our neurologists. So basically the statin stabilize the plaque, and that's all the evidence show that. Now, building up the plaque, okay, also prevented by statin. Now, shrinking the plaque is done by PCSK9 and is IVUS. We look at the artery as we do. We look at that, and it's shrinked. It gets shrinked, you know. So now people thinking about regression, disappear of the plaque. Can we do that? I think it's coming, you know, because as Dr. Hassan says, no, now we have an injection we can give twice a year. Then future will be like vaccination once a year. Then gene. So all coming. It's just the education. I think we should communicate. Not just to we confine to ourselves as a cardiologist, but that's why this kind of meeting really, you know, is the benefit of the patient. It's not just for us to show off anything. No, just really we want this service to reach our patient and they so live longer. Dr. Hassan, your comment, please.
Yeah, I think it's brilliant discussion. No, I think we need to be progressive in our thinking. I think, unfortunately, most of the trials is showing that compliance is really bad. I mean, you know, the first 3 months, and even on a smaller dose, let alone the 80 milligram that we always push for, it's really, first of all, we need to engage with the patient a lot. I mean, some of my patients, I bring them every 3 months sometime, if I need to keep an eye on their level. But as a whole, I think we have multiple interventions. And I mean, now for the GLP-2, GLP-1, I mean, it's fascinating how these medications are impacting, and they are all injectables. So as a whole, I think we definitely have to get to the target. But at the same time, I am getting a little bit, frustrated by the insurance of unable to prescribe the PCSK9. I think, and I don't give up. It may take me sometime 5-6 times that I have to write and justify for acute PCI, whatever they do. But in those patients who have very high levels and you cannot achieve it with the statin and ezetimibe, I think we need to go for a more powerful. It's very, it's difficult really. But imagine giving the patient once or twice a year. It's a huge benefit to the patient where they can just forget it. And I agree with Dr. Pounami that the multi-pharmacy and the many medication, and patients take their blood pressure medication, but they resist taking their lipid lowering. And they have tons of funny ideas about the side effects and the social media and all the rest of it. We try hard. We try to educate them, sending patient to the dietitian. I use my dietitian a lot. And I think that because people, they're not aware of the amount of fat and calories in their food. So we do multiple issues. But as a whole, I am hoping that, and coming back to your point, I think PCSK9 initially, we were not about inflammation and all the rest with the statin. But now the outcome trial is showing regression. And there is now a recent paper in New England Journal of Medicine about inflammation also. So I think they're following the steps of statin being a vascular medication, whether it's for the heart or for the brain and what have you.
So an important point, just again, because our neurologists here and attendees here are different specialty, is LDL you do is fine, but even if you go to the goal, patient, need to do something called non-HDL, especially in diabetic, because there are, remnant. These are the one we cannot see it with LDL. It's very easy, it's very easy to calculate it, so it's just total cholesterol minus HDL. You will get, and that should be less than, 30, the 70 for LDL should be like, less than 100. So that's very important. Second thing, triglycerides, we have a data. I mean, again, is a new omega-3. It's not the one we are using from the shop. It's a prescribed medication, and it's tested dose. I know it's a big dose, but it is there. This is indication for it is there, as Dr. Hassan says. But again, not everyone. There are certain patients for that. So basically, we have all the methods and the ways and medication and lifestyle, many things. But the most important is our communication with our patient. Wallahi, if they don't, not adherence, whatever you give them, is, they bring you bags of medication, but they don't take it. What's the point? So I want really at this last 3 minutes, Dr. Suhail,
Abdullah, yes. Dr. Abdullah, I have a question to Professor Hassan. I'm so glad that Pounami is here also. The primary prevention with the people who's going to the family doctor, and they found that in their early 40s or mid 40s with a high dyslipidemia. It's very common within the community of local Emirati or the citizen of UAE or the resident of UAE. That how can we treat these patients? You will advise them as a family doctor, diet control, they will see your dietitian, they will do sport, but this will continue only, believe me, for 3 months, then they will go back to their normal life. How can we advise? And there's a strong family history in that patients with the coronary heart disease or stroke. What's your guide, Professor Hassan?
Yeah, no, absolutely. I think this is critical. I think we're focusing on the high risk, but the majority of patients, I mean, you see, people talk about primary versus secondary. I personally don't believe in that. I think The disease is there. When it declared itself, so I have a patient just recently, he smokes high cholesterol, and he comes and tells me, oh, but I cycle 20K a day. I told him, one morning you'll wake up with a heart attack, and I wish I didn't say it, and it happened. So plaques do not appear. Atherosclerosis streaks are seen as young as 10 years old. So when somebody has a plaque sitting there and you get an inflammation, I mean, we do CAT and we have 5 lesions. One of them ruptures. When does it rupture? So the key primary prevention is not a lesser disease. It's a hidden disease. And I think for the benefit, you have to be as aggressive because you want to prevent. What's the point of patient having an MI and then we treat them aggressively? I'd like to prevent the MI. And therefore, I put a lot of my patient, but I tell you, it's the time you invest in the patient and show them the risk. And there are multiple risk assessment, the British, the American, the ACC, AHA. And I really always say, please risk assess your patient and show them the risk and how much you can do. And for me, it doesn't matter, primary, secondary, I want to treat the disease and prevent the MI from happening.
So in those patients who have not event yet, we call it, a kind of primary prevention. So they, so they know. But I think, Dr. Suhail, if you're speaking about the familial hyperlipidemia, those who are above 190, this one you need to really any aggressive management, similar to what we do for secondary prevention. We need to bring it down. We use all medication. Again, we did a study on the heterozygous familial is double in what's in the world. So 1 in 150, rather than 1 in 220. So we are higher in terms of management. And I think, one way to convince me and Dr. Hassan, I think we do this. Sometimes people don't look at the numbers. Say, look, I'm 160. I myself, the other day, I did LDL is high as well, like around 150. We are doctor very bad as well. So how can I convince myself to take medication or not? I do something called CT calcium scoring. Okay. I sometimes do, if I'm a certain age, I do a CT coronary angio. If there's a soft plaque and there's a calcification there, khalas, you have to take it because the disease already. So why we treat the risk? Because to prevent the disease. If the disease is there, khalas, you have to treat it as a secondary. So this is way of convincing your patient, really, if they don't look at the number. So any other final points?
Dr. Abdullah, I think the key element is the load of risk factors on the vasculature. We shouldn't look at lipid level as a number. A little bit of cholesterol and a bit of high blood pressure and a bit of diabetes, that's what caused the plaque rupture. So if somebody has, and if you look at Framingham, which is the simplest form of risk assessment, you may have 160 of LDL, but you have no other risk factor. Your risk score is very low. It's really, when you put them together, that and that's why the score that we see with the guideline is about cumulative effect of risk factors on the vasculature, and subsequently, those patients are sitting like a time bomb, and they would, diabetes, high blood pressure, a bit of cholesterol, and that's the recipe for immediate myocardial infarction, regardless of how much LDL do you have or how much blood pressure and what have you.
Yeah, and very clear message, Professor Hassan. Just I'm sitting here and thinking when I should get Abdullah and Professor Hassan to one of our neurology congress, because this is something new. We are busy with our multiple sclerosis, dementia, and Alzheimer patient. Speaking at this level, this is something, Pournami, maybe you have been preparing for this presentation, but this is something is evolving in the field of dyslipidemia. What do you think, Pournami?
Yes, definitely. And as you told also, like patients for whom, if there is a positive family history and LDL is elevated, when you say that you have to start on medications, in the next knee-jerk reaction is, I will try exercise and diet control and then I will check again. Nobody wants to start on medication. So I think if you have something like Dr. Hassan mentioned, once in 3 monthly injection or 6 monthly injection, things will be much different actually.
It goes with the lifestyle. What you want,
yes.
nobody tolerate even medication for 1 week. You know, you only get antibiotics. You cannot not complete it. So let us
Last day, this.
yeah, so let us, I think that this kind, as Dr. Suhail said, this is kind of collaboration and communication make our, you know, to re-look at our, because we talk so much narrowed, we think only cardiologists or only neuro, but when we talk together, we see how much gap is there in terms of management. But inshallah, together we can reach and you know the goal. So really, I would like to thank Dr. Suhail, my brother, and really have been great supportive of this meeting. This is our final one together, fighting the stroke. Inshallah, we'll do more of these events in a different, and we come maybe with a guideline as well, some pathway for UAE. And I'd like to thank Dr. Hassan and Purnami and Dr. Suhail. You want to say something as well? And of course, the ICOM. Thank you very much.
Thank you very much. Thank you, Professor Hassan. Thank you, dear Purnami, for this nice night. And thank you, Ziad and ICOM. Abdullah, all the support that we are getting for these type of webinars, you are behind this, and you are giving the flavor for these type of webinar. Thank you, Abdullah.
Thank you for a brilliant chairman who ran a beautiful discussion. We'll see you again, inshallah.
Assalamu alaikum.
Thank you.
Thank you, Purnami. Thank you.